Hello, and welcome to your first narrated lecture on heart failure. Let's have a quick review of the normal anatomy and physiology of the way blood normally flows through the heart. Let's trace a droplet of blood as it enters into the superior or inferior vena cava. So imagine that, let's trace a drop of blood from our kidney. So the blood comes out of the kidney and it enters into the inferior vena cava and it travels all the way up. It enters the right atrium, and from the right atrium it flows through the tricuspid valve, from the tricuspid valve to the right ventricle, out the right ventricle through the pulmonary valve, into the pulmonary artery carrying blood from the ventricle to the lungs. In the lungs, it will get oxygenated, and then it will travel from the lungs to the left atrium, from the left atrium through the mitral valve, from the mitral valve into the ventricle, left ventricle, and from the left ventricle out into the aorta, and from the aorta into the rest of the body. It's important for you to know that if you do not know it already, like the back of your hand, because we are going today to be talking about problem with the heart when it cannot pump like that. Cardiac terminology. Let's review some of the basic things that you should know from last year, but we want to make sure you have a good solid foundation this year. Cardiac output. Cardiac output is the amount of blood that is pumped in 1 minute. So cardiac output is calculated as heart rate times stroke volume. Stroke volume being the amount of blood that comes out of the ventricle with each beat. So cardiac output allows us to meet the oxygen and nutrient demands of the body, and anything that would affect heart rate or stroke volume will affect cardiac output. And let's talk about some of those things that will affect heart rate and stroke volume. Let's start with preload. Preload, according to your definition here, the volume of blood in the ventricle at the end of diastole before the next contraction. So preload is a volume. So we would say preload is the amount of pressure in the ventricle, or the amount of stretch caused by the volume of blood in there. Anything that affects the amount of blood returning to the heart will affect preload. What affects the amount of blood returning to the heart? Well, something like hemorrhage or dehydration or diuresis. Those will decrease circulating volume. If we have vasodilation, that will decrease the amount of blood returning to the heart because it'll stay in the body. So all of those things affect preload, and preload is the volume of blood that is in the ventricle, the volume of blood that has returned, venous return to the heart is another way to say it, and that affects cardiac output. Afterload is the amount of pressure the heart must overcome to eject blood from the ventricle. Under preload, go back on your slide and underline the volume, and right next to it stretch. So the preload is volume and stretch, whereas afterload, underline the amount of pressure that it takes the heart to overcome to get blood out of the ventricle. So we can use the word for afterload. You can replace that with systemic vascular resistance. So the amount of resistance the vessels cause to get blood into the system, or pulmonary vascular resistance, meaning the amount of pressure that the right ventricle has to overcome in order to get blood out of the right ventricle into the pulmonary beds. Afterload, we have systolic vascular resistance, which is a high pressure system. That means it's really hard all the time for the left ventricle to get blood out of the ventricle and into the circulation. So systemic vascular resistance is a high pressure system, as opposed to pulmonary vascular resistance, which is a low pressure system. It's usually very easy for the right ventricle to spill blood into the lungs. Okay, let's move on and talk about contractility. Contractility is the amount of stress, the amount of stretch that the ventricle has. And the amount of stretch, how stretched out it is, gives us the ability to squeeze. So contractility is a muscle squeezing to be able to empty the ventricle. Let's talk about contractility just a little bit. The heart requires just the right amount of blood to return to the heart. That's preload. And when I get just the right amount of blood returning to the heart, then I have just the right amount of stretch in my ventricles. And when I have just the right amount of stretch, I get the maximum contractility, the maximum squeeze. So there is a theory that says the more you stretch something out, the greater the contractility, the greater the squeeze. And that is true to some extent, but just like a balloon, when you blow a balloon up one time, you blow it up really high, so it's really, really big. You let it go, and it zooms all around the room. And you might be able to do that 5 or 6 times. And each time you blow it up really, really big, it's a little less difficult to blow it up big the next time. And it stretches out, and it gets kind of weak. And eventually, when you blow it up that big, the balloon gets kind of out of shape, and it's bigger than it was, but it's not able to blow the balloon around the room like it used to, because the amount of it had too much stretch, and the contractility is not there. So contractility is really important when we're talking about how hard the heart can contract. So cardiac output, to review, cardiac output is heart rate times stroke volume. Preload is the amount of volume that comes back to the heart, and that volume causes a certain amount of stretch. And when I get that certain amount of stretch, my heart is able to have strong contraction to eject the blood out of the heart. And when it's ejecting the blood out of the heart, we are talking about afterload, the amount of volume or the amount of pressure it takes to eject the blood from the ventricle. So ejection fraction. Ejection fraction is the percent of end diastolic volume that's ejected with each contraction. So your definition here on the paper says the amount of blood that's ejected from the left ventricle per minute. Okay, so it's the percentage of end diastolic volume. What does end diastolic volume mean? That means at the end of filling, at the end of diastole, it is the percentage of the blood that is able to be ejected from the heart. Normally, we eject 55 to 65% of what is in the ventricle. That's what's ejected from the heart with each contraction. A person is said to have heart failure when their ejection fraction is less than 40%. I think that's an important number for you. Okay. Then here's a term that we see, and that is cardiac reserve. The cardiovascular system's ability to adjust heart rate and stroke volume in response to various situations. What does that mean? Heart rate times stroke volume equals cardiac output. If you are going to run 2 miles, get up out of your chair and run 2 miles, you would increase the oxygen demand for your tissues. And you would adjust, in order to adjust for that increased oxygen demand, you would need more cardiac output. You would need more blood circulating oxygen to the tissues. So your body would increase the heart rate. And when heart rate would go up, cardiac output would go up. We can measure cardiac output. There's certain assessments that we're going to make for cardiac output, but we can measure cardiac output by measuring a mean arterial pressure, a MAP. And a normal MAP, depending on the source that you're looking at, is 70 to 110 millimeters of mercury. Most sources will agree that over 80 is adequate. And what we do know is that less than 60, there may be inadequate perfusion to the organs. So a mean arterial pressure is a way that we monitor cardiac output. So remember, greater than 80, good to go. Less than 60, there's possible organ perfusion problems. Important again to remember, preload, afterload, contractility, and heart rate affect cardiac output. Let me say that again. Preload, afterload, contractility, and heart rate affect cardiac output. All right, let's talk about things that affect heart rate and cardiac output. That would be the autonomic nervous system. If you are not completely familiar with the autonomic nervous system, sympathetic and parasympathetic nervous systems, go back to your anatomy and physiology book. Go back to your Lewis textbook and check it out. You need to know. We talk about the autonomic nervous system repeatedly in this course. So it's better to know it up front than to take an entire semester to finally get all the pieces put together. So let's talk about the sympathetic nervous system. We'll say the sympathetic nervous system is mediated by catecholamines, epinephrine, norepinephrine, dopamine. They, when stimulated, will stimulate the beta receptors. And when we stimulate the beta receptors, we have an increased heart rate. We have vasoconstriction in the arterioles, and we promote the release of renin. We also increase the amount of sugar that the liver makes. So let me say that again. The sympathetic nervous system is mediated by catecholamines. When stimulated, they stimulate the baroreceptor or the beta receptors, and the beta receptors increase heart rate. The catecholamines actually have they directly stimulate the beta 1 receptors in the SA node to increase rate. So that's how our heart rate goes up. And they cause vasoconstriction in the peripheral arterioles, which increases afterload. And it promotes the release of renin, which is going to also increase blood pressure. So how does the body know when to release these catecholamines? The body knows how to release these catecholamines because of baroreceptors and chemoreceptors. Baroreceptors are in the arch of the aorta, and they are sensing pressure or stretch. So when they are in there and they feel a lot of pressure, a lot of stretch, meaning that blood pressure is elevated, these send a message to vasomotor area in the brain, and it tells that part of the brain that slow down the sympathetic response and increase parasympathetic activity. Parasympathetic activity, which we'll talk about in a second, slows everything down. Rest and digest is what we think when we think parasympathetic. So the sympathetic nervous system increases heart rate by stimulating the beta-1 receptors in the SA node. It causes vasoconstriction in the peripheral arterioles, and it causes an increase in renin, and it causes an increase in the release of insulin, or sugar, not insulin, causes an insulin resistance, but an increase in sugar from the liver to increase stores available for energy. And so, when we feel lots of stretch, a high blood pressure, lots of volume, baroreceptors send a message to the brain, slow down the sympathetic system, kick in the parasympathetic system. And converse is true as well. When there's not enough stretch or not enough pressure, the baroreceptors send a message to the vasomotor center in the brain. Hey, let's have a sympathetic nervous response. We need vasoconstriction. We need an increase in heart rate. So the autonomic nervous system is affected by messages coming from the baroreceptors. As well, the chemoreceptors. Chemoreceptors have more to do with the pulmonary system. Put a little star next to that. Not that you necessarily need to know it, but I want you to know it is sensing information from the respiratory system such that those chemoreceptors are responding to a decrease in PaO2, an increase in PaCO2, and acidosis. So when oxygen levels are down, carbon dioxide levels are rising, or there's an acidotic state, messages are going back to the brain. So when PaO2 is low and CO2 is high, we need to have an increase in the sympathetic nervous response so that we can improve perfusion. So chemoreceptors, when O2 is low, CO2 is high, and pH is low, we have an increase in the sympathetic nervous response. Now, to go back to the parasympathetic nervous system, it's mediated by the vagus nerve, and the neurotransmitter is acetylcholine. We say rest and digest. It slows down conduction to the SA node. So it slows down heart rate. Has a lot to do with digestion and other things, but right now we're just talking about things that affect heart rate and blood pressure. So, the parasympathetic nervous system is mediated by the vagus nerve, and acetylcholine is the neurotransmitter, which is important for you to know because we give a lot of anticholinergic, and anticholinergic means anti-acetylcholine. So it's responsible for rest and digest, and it slows the conduction to the SA node. Okay, let's talk about heart failure. By definition, it is a syndrome. It's not a disease, so it's a syndrome, meaning it's a cluster of symptoms characterized by signs and symptoms of decreased tissue perfusion and fluid volume overload. It is, I'll say, a cardiac disorder that decreases the heart's ability, or decreases the ability of the ventricle to fill or to eject enough blood to meet the oxygen and nutrient demands of the tissues. So it's an inability of the ventricle to pump enough blood to meet the oxygen and nutrient demands of the body. It is progressive, and it causes cardiac remodeling. We'll talk about that, what that means in a minute. But it's important that you understand, once you have it, you always have it. We can hope to improve your symptoms. We can hope to manage quality of life, but you always have it. It affects 6 million people worldwide. 550,000 new people a year get it. 20% of the people who get heart failure will die in the first year. 50% will die within 5 years. That's big statistics. So half million people get it a year. 20% of those 500,000 will die in the first year. 50% will die at the end of 5 years, and it costs the United States alone $39 billion a year to take care of people with heart failure. All right, let's talk about the etiology. Where does it come from? How do you get it? And understanding all the different ways that you get it. There are many things that cause heart failure, but we already said that it was progressive, but it has to start someplace. There has to be some sort of an etiology. There has to be some sort of an initiating event. So the etiology in general, I would say, are things that are going to impair cardiac function. Anything that's going to increase the workload of the heart. And when we say increase the workload of the heart, that means asks the heart to work a little bit harder, thereby increasing the heart's oxygen demand, the heart's need to get oxygen. So anything that impairs cardiac function, things that will increase the workload or O2 consumption, a valvular disorder, all kinds of things that we'll talk about that will do those that will increase the workload of the heart. Let's talk about coronary artery disease, because coronary artery disease is the primary cause for heart failure. 60% of the people who have heart failure have coronary artery disease. So what is coronary artery disease? I want you dusting off all the cobwebs from freshman year. So you remember that is the deposit of all these plaques in the coronary vessels, which decrease the elasticity, which decrease the amount of stretch that those vessels are able to have. It also decreases the diameter of those vessels, and it causes hypertension. And when I have that hypertension, I increase the oxygen demand. I increase the workload of the heart because I have increased afterload. I have increased the amount of pressure it takes the ventricle to overcome and pump the blood out. So when I have coronary artery disease, and in all my coronary vessels, I'm giving myself hypertension, which is one of the causes down there. And number two, I'm also causing ischemia to the myocardial muscle. So that ischemia, or lack of oxygen, because I have all those plaques and because I don't have the correct circulating volume, I have myocardial dysfunction. That means the heart muscle isn't working like it should be. It's not working like it should be because it's depriving the heart cells of oxygen. And when I deprive the heart cells of oxygen, they're damaged. And damaged cells don't pump as well. So I have an impaired pumping. So if I have impaired pumping, I have a decrease in cardiac output because my stroke volume isn't there. So coronary artery disease leads to hypertension and increasing the workload of the heart. Coronary artery disease also leads to ischemic heart disease, and the ischemic heart disease causes the blood cells, muscle cells in the heart to be damaged, and those damaged myocardial cells impair the pumping action or impair cardiac output. The next thing could be an MI. So an MI, we remember, is a blood clot in one of the coronary vessels, and that blood clot causes myocardial ischemia and maybe even myocardial necrosis, which results in we get a blood clot, we have ischemia, and then we have focal necrosis, they say. That means just the area on the other side of the blood clot. We get collateral circulation, you remember from last year, but you have an area of necrosis, and that necrosis means that there has been cell death. And when there's cell death, that means that that area of the heart does not contract. That means I have a decrease in contractility. If I have a decrease in contractility, I have a decrease in cardiac output. And why do I care? So coronary artery disease causes a decrease in cardiac output, and an MI causes a decrease in cardiac output, because that's what heart failure is. Heart failure is a decrease in cardiac output, because a decrease in cardiac output means the cardiac output, or the blood that the heart pumps, takes oxygen and nutrients to the tissues. It takes away waste products. So if I don't have the proper cardiac output, I don't have the proper nutrition, and I don't have the proper oxygenation, and I get general cell death, of my foot, of my hand, of my kidney, of my brain, of my lungs. So that becomes a problem. So, next we move to hypertension. We could have systemic hypertension or pulmonary hypertension, because both sides of the heart pump into a vascular bed. The right side pumps into the pulmonary vascular bed, and the left side pumps out to the body. And if I have hypertension, that means that there's vasoconstriction or pressure of some sort, either in the pulmonary beds or in the vasculature, in the periphery, in the body. I increase the amount of work that my heart needs to do to pump blood out of the ventricles and into the body. And when I increase the work that my heart has to do, I've increased the amount of oxygen that my heart needs. So, when we have hypertension, we have an increase in afterload. Structural defects. Valves are one way through. When you go into a parking lot and they have the treads that will pop your tires if you go the wrong way. Well, it's just like that. Blood is going to move from the atrium into the ventricles, and we're not supposed to have any backflow. So, if we have a problem with one of those valves, and we don't have one-way forward flow, right atrium, right ventricle, left atrium, left ventricle, we have some backflow, we increase the amount of pressure. And when I increase the amount of pressure in one of the chambers, I am changing the preload, I am changing contractility, I am changing cardiac output. So valvular problems, structural defects in the heart that prevent one-way flow and cause backflow and increased pressure can cause heart failure. Cardiorenal syndrome. Next week we are going to do the renal system, but when we have renal disease, we have an increase in volume. We have fluid volume overload, and that fluid volume overload, the extra preload, the extra stretch that the heart has, lead to an increase in workload and can lead to heart failure. And then the last one down there, others, that would be things like an increased metabolic rate. So somebody who has hyperthyroidism, somebody who has hypoxia, because we're going to talk about the role hypoxia plays with increasing pulmonary vascular hypertension. somebody with severe anemia where we don't have enough oxygen carrying capacity, so the heart's working really, really hard. They're just some of the others. Okay. Let's talk about pathophysiology. Let me give you the big overview. We're supposed to have forward flow, I said. So we're supposed to have forward flow, and that means that the blood goes right atrium, right ventricle, left atrium, left ventricle. And if I have a problem where I don't have enough forward flow, then if I have a problem where I don't have enough forward flow, I'm going to have a backup. And that backup of blood is going to cause an increase in pressure. And if the blood on the left side of the heart can't get out and it backs up into the lungs. And when it backs up into the lungs, I have all this fluid in there, and I get all this congestion, and I impair tissue perfusion. If enough blood can't get out of the left side of the heart, and it can't pump blood to the organs, then I don't get enough oxygen to the organs, and I say I have a decreased cardiac output. If the right side of my heart doesn't work and the blood backs up, it backs up into the body, and I have all this edema. That's the big 30,000 foot big picture. But let's look at it and break it down little by little. And since the number one cause for 60% of the people is coronary artery disease and hypertension, I'm going to use my example to be someone who has hypertension related to coronary artery disease. So someone has hypertension related to coronary artery disease. Sorry, I'm fixing this microphone. And that means that they have an increase in vascular resistance. They have an increase in afterload. So I have increase in afterload, an increase in the vascular resistance. That means I also have an increase in the force of left ventricular contraction. That means that my left ventricle has to work really hard to pump blood into that very small vessel. If you're pumping blood into a vessel that has a 2-foot diameter, it's really easy. If I take my 2-foot diameter and squeeze it all the way down to 1 inch, it's really hard for the body, for the ventricle, to pump into that 1-inch diameter vessel. So the left ventricle is working very hard. The left ventricle also has an increase in oxygen demand because it's working so hard. And with the increase in oxygen demand, and remember now my person has coronary artery disease, so they have high blood pressure, but they also have coronary ischemia happening, right? There's not enough oxygen getting back to that heart because the coronary vessels are all clogged up. They only gave it a 1-inch diameter and it needed 2 feet. So now I have left ventricular hypoxia. And so when I have left ventricular hypoxia, that means that it's not working as well. That means it's starving for oxygen. And that might be why I get some chest pain that manifests itself as angina. But when I have that hypoxia, I have a decrease in the force of the contraction. That means that it's not working as well. It needs to work harder, but it can't work harder. It worked harder for a while, but it increased the oxygen demand, and then it didn't get enough oxygen, and now it has hypoxia, so the left ventricle begins to slow down. So it has decreased the force of the contraction. And when I decrease the force of the contraction, I have a decrease in cardiac output. But we said that the body has something called cardiac reserve. Remember when we did our terminology? A cardiac reserve is the body's ability to maintain homeostasis, to increase heart rate, to change stroke volume, to do whatever it needs to do to maintain cardiac output. And the body's really pretty good at that. So let's talk about some of the earlier things where there is some discussion in the literature as to whether these are early parts of heart failure or whether they're compensatory. Either way, it doesn't really matter. It happens very early, and I want to explain those to you. So we said that when we have stretch, when blood comes back to the heart, we get a lot of stretch. And that stretch causes a contraction to happen. And the more you stretch it, the better the contraction is to a certain point. Like the balloon, it was good for, another 30,000 beats with an extra stretch in it, and it was doing a good job. And the heart, the pressure, the blood couldn't come out of the left ventricle, so it kept stretching and stretching, and that was good to an extent. But after it starts stretching and stretching, soon all the elasticity is gone, and it's like that old worn out balloon. So that was like a first compensatory mechanism that it was doing. So, and then we said, so it's trying to work really, really hard. So it dilates. So there's vascular resistance. The blood can't come out of the heart. So the left ventricle starts to beat harder. It starts to dilate because there is a backflow of blood. It's not getting out. So the heart stretches and stretches and stretches until it stretches just too far where it's lost the elasticity. And the heart, then the muscle is working super hard now because it's lost the elasticity that was helping it out. And now the heart is a muscle. And if you go and work a muscle, I say every year, if I send all of you to the gym, I say, okay, we are going to get really strong biceps. And I want you to go and do all these arm workouts. You're lifting weights, you're doing push-ups, you're doing pull-ups. You are going to come back in 2 weeks, and I'm going to say, wow, look at the muscles of this whole class, because your arms have been getting bigger and bigger and bigger. Well, the cardiac muscle will do the same thing. So first, it was working harder. It had an increase in oxygen demand. It tried to compensate by allowing extra stretch until it stretched too far and lost its elasticity. And now the heart's working even stronger and harder than that. And so it's working out. And what is it doing? Since it is a muscle, it's getting thicker and thicker and thicker. And when we get a thick arm muscle, it's a strong muscle, and you can do lots of work with it. When the heart muscle gets big and thick, it does a couple things. Initially, the heart working harder helps to maintain cardiac output. But after a while, when it gets extra big and thick, it makes it harder to stretch because it's big and thick and it's not paper thin like that balloon was. So then it has poor contractility. But the heart's working really hard, so the increase in the oxygen demand. But there's poor coronary perfusion because the blood is not coming out. We don't have the cardiac output, so there's ischemia back to that heart. And that ischemia is causing dysrhythmias, which is causing uncoordinated ability to contract and get the blood out. So that is what we call left ventricular remodeling. So we have this myocardial dysfunction that results in poor forward flow. The blood can't leave the heart. There's an increase in afterload, an increase in systemic vascular resistance. The ventricle starts working really hard, which increases the oxygen demand. We have poor coronary flow back to the heart, so we have ischemia. At first, to maintain stroke volume, we have extra stretch. And that extra stretch is good for a while until we lose the elasticity and it becomes a bad balloon. And then now the heart's working really strong again, and it's pumping extra strong. It's lifting weights. And again, in the beginning, that helps to maintain stroke volume. But when it works that hard for that long, it becomes thick and it becomes less elastic. And then I don't have the ability to fill, because I used to have a chamber that had a space that could hold 1 cup of fluid. And now it got a big, thick muscle, and now it only holds 1 ounce of fluid. So I have less stroke volume in there. I have a muscle that doesn't stretch like it used to. So that poor inability to contract increases my oxygen demand. It's decreasing coronary perfusion because the heart's not pumping out enough. It's causing generalized ischemia to the heart as well as the tissues, and it's causing dysrhythmias in the heart, which make contraction, the electrical conduction is impaired. Now that's a big problem. So that's what happens initially, and our body is really good. Our body is really good at coming up with compensatory mechanisms to decrease cardiac output. Let me go back to your slide. Myocardial dysfunction resulting in poor forward flow. The ventricular remodeling is the stretch, the dilation, and the hypertrophy. And those things lead to a decreased cardiac output. And if it's on the right side of the heart, it leads to fluid volume overload. Now let's talk about the compensatory mechanisms. We talk about neurohormonal compensation. That means that all those things happened. We had the dilation and the stretch, the balloon effect. We had the hypertrophy. And we still have decreased cardiac output. So the body's like, okay, at all costs, we have to maintain the right mean arterial pressure. We have to maintain the right blood pressure, because if we don't, then we're not going to get enough oxygen to the tissues and we're going to have tissue death. So the first is a sympathetic nervous response. It's the least effective compensatory mechanism we have. It's also one of the first. And that is stimulation of the baroreceptors. And we remember those baroreceptors are in the arch of the aorta. When there was decreased cardiac output, when there wasn't enough blood coming out, when there wasn't enough stretch in the aorta, the baroreceptor sent a message to the chemoreceptor center in the brain, to the motor receptors in the brain, and it said, increase the sympathetic nervous system. So it did increase the sympathetic nervous system. It increased heart rate. And that helps, because heart rate times stroke volume equals cardiac output. So if I increase heart rate, and my stroke volume is down because that's the problem, my left ventricle is not pumping enough. But if I increase heart rate, I'm going to beat enough times that I can maintain cardiac output. But we remember that one of the other things that the sympathetic nervous system does is cause vasoconstriction in the periphery. Okay, well, vasoconstriction in the periphery can help, and I'll explain it in a minute, can help very temporarily to increase cardiac output. So just hold that thought. But for the most part, maybe very, very early on, for a couple minutes, for a very short period of time, the sympathetic nervous response of the peripheral vasoconstriction may increase cardiac output, but for the most part, peripheral vasoconstriction causes an increase in vascular resistance. It causes an increase in afterload. The heart's already having a tough time overcoming the 1-inch diameter that it has to go through because of the coronary artery disease. If I cause further vasoconstriction, that's going to be a problem. So the sympathetic nervous system, the baroreceptors are stimulated. We have an increase in heart rate. We have an increase in vasoconstriction, and we have an increase in renin. That comes from the sympathetic nervous system. Now, let's talk about RAAS, renin, angiotensin, aldosterone system. Renin, angiotensin, aldosterone system. The kidney is the major regulator of blood pressure in the body. The kidney is an extremely stingy organ. When it is not getting the exact right amount of blood flow, it has the ability to increase flow. And the way it does that is through this RAAS system. So there's not enough perfusion to the kidney. Why would the kidney not be getting enough perfusion? The kidney's not getting enough perfusion because the left ventricle is trying to overcome such huge pressure from the coronary artery disease, and it dilated and it got hypertrophy, which further complicated the ability to pump. It's impaired cardiac output. And the impaired cardiac output means that there's not enough blood, there's not enough oxygen getting to the kidney. So the kidney's going to go, okay, I'm going to release renin. And renin is going to travel to the liver, and it's going to take angiotensin and convert it to angiotensin 1. Angiotensin 1, this is all very important stuff that I'm teaching right now, has a lot to do with pharmacology. So angiotensin 1 is a vasodilator. And angiotensin 1 will travel and meet with ACE, angiotensin converting enzyme, which is made in the lung. And it will convert angiotensin 1 to angiotensin 2. Angiotensin 2 is a powerful vasoconstrictor. In addition to being a powerful vasoconstrictor, it is going to increase aldosterone. Aldosterone holds on to sodium and water, which will increase circulating volume. Those things will increase blood pressure. So let's think about this. Let's think about, it's the middle of July when I'm doing this recording for you. It's hot, it's humid, and I'm going to ask all of you to get up out of your chair. I'm going to ask you to go outside and run that 2 miles that we talked about. So you go out there and you run 2 miles. I didn't give you any water. It's hot, it's humid, you're sweating. And you get back and you sit down, take a little rest, still don't have a drink. And what happens? Your baroreceptors are saying, I don't have enough stretch. So they send a message to the brain that says, cause and get an increased heart rate to increase circulating volume, to increase the amount of oxygen getting around. It increases a little bit of renin, and the renin causes vasoconstriction and aldosterone to be held onto. The kidney says, I'm not getting the perfusion that I need. I'm not getting the oxygen that I need. So it sends out renin to angiotensin 1, which meets with ACE and turns to angiotensin 2. And angiotensin 2 now is causing vasoconstriction. The sympathetic nervous system is causing vasoconstriction. The angiotensin 2 is increasing aldosterone, which is holding on to sodium and water. And for you, after you've run 2 miles in the heat and sweating, that's a good thing. Because now aldosterone's holding on to sodium and water, so it's trying to hold on to volume. And when you hold on to volume and stop spilling sodium and water, that will bring your blood pressure back up. In addition, the vasoconstriction will help to increase perfusion. Let's think about a garden hose, and let's think about a garden hose without a spray nozzle on the end and a garden hose with a spray nozzle on the end. If I take a garden hose and I have no nozzle on the end. I turn the spigot on. Water is going to pour out. It's going to just arch out of the hose. But the thing is that I want to spray 25 feet away. I need to get far away from here. So what would I do? I can put a spray nozzle on that changes the diameter of that hose. It was a 2-inch opening where water was coming out, and now I squeeze it down to a 1/4-inch opening, and now I have vasoconstriction. So now I can squirt that hose 25 feet away easily because I have vasoconstricted. I have narrowed it down. And so now I have vessels that are pushing, that are smaller, and they're pushing what blood is left forward to the organs. And that's how it normally works. But somebody who has heart failure, one more thing, and then ADH, when the left ventricle fails to pump enough blood, when cardiac output is impaired, and their cerebral perfusion is impaired, that means the brain is not getting the oxygen that it needs. It sends a message to the adrenal gland, and the adrenal gland is going to release ADH, antidiuretic hormone, and that antidiuretic hormone is going to hold on to water. So again, for the person who ran the 2 miles, now they're holding on to more water. So ADH just does water, aldosterone does water and sodium. So when you run a mile, vasoconstriction will help get perfusion, help get oxygenated blood to your kidney and to your brain, and we're holding on to extra fluids, which increases volume. When I have heart failure, that's a problem. Holding on to extra fluid, I don't need to hold on to extra fluid. I've got plenty of fluid. It's just that I can't pump it forward. I don't need any more peripheral vascular resistance or pulmonary resistance by vasoconstriction because that's the problem to begin with. The vascular resistance is so high, it's causing the left ventricle to fail. So all of these things cause increase in afterload and an increase in circulating volume, which further compound the problem of altered cardiac output. Let me see what else I want to tell you about that. I think one more comment about ADH and understanding ADH. ADH is released in response to decreased cerebral perfusion. It comes from the posterior pituitary. We also call vasopressin when we give it as medicine. It increases the renal tubules' ability to hold on to water. The other thing that it does is it stimulates the endothelial cells, so the lining of the vessels, to produce endothelin, and endothelin is a vasoconstrictor. So each one of these things, SNS, RAAS, and ADH, has the ability to vasoconstrict and to hold on to fluid. Vasoconstrict comes from stimulant in the sympathetic nervous system, stimulating the peripheral vasoconstriction, and it increases renin. Renin and aldosterone in the renin-angiotensin system, and ADH holds on to water, and then it stimulates the endothelium to make the endothelin, which is a potent vasoconstrictor. And it also, and then the endothelin itself, it does vasoconstriction because it stimulates, it actually stimulates catecholamines and angiotensin II receptors. And then the last thing on this slide is pro-inflammatory cytokines in response to cardiac injury. We're going to talk about this in 2 weeks, I believe. These pro-inflammatory cytokines, when we have injury, cardiac injury, we'll have, just put a little star there because it's too much to explain now. You'll understand it in 2 weeks and you'll understand it for the test. But it eventually, it results in cardiac contractile dysfunction and cell death, and it's actually believed that in long term, towards the end of the disease process for heart failure, these pro-inflammatory cytokines actually cause a systemic inflammatory response, which means nothing to you now, but in 2 weeks, hopefully, it will mean a great deal more. Okay, so eventually, we had all the cardiac remodeling, and then we had these compensatory mechanisms kick in that we just talked about. But eventually, the body can't deal. It just, the amount of fluid becomes too overwhelming. The amount of back pressure becomes too overwhelming, and we have the release of these counterregulatory processes. And these counterregulatory processes is the release of natriuretic peptides, ANP and BNP. ANP comes from the atria, BNP comes from the ventricle. And when we call this, it's mostly BNP. So when the ventricle gets too stretched out, there's too much volume in it, we were not able to produce enough forward flow, this BNP is released, and in relation to the stretch. And what does BNP do? We call it nature's diuretic. It increases GFR, glomerular filtration rate, and therefore increases diuresis. It causes the excretion of sodium. It causes vasodilation, therefore a decrease in blood pressure. It works to inhibit renin and aldosterone, and it interferes with ADH. So we're trying to counteract the sympathetic nervous system, the renin, angiotensin, aldosterone, and the ADH. So body releases nature's diuretic, this BNP and ANP, which cause diuresis, the loss of sodium. It's causing vasodilation. It's trying to impair renin, aldosterone, and ADH, which hopefully will decrease volume and decrease blood pressure. The other thing that's released is nitric oxide. Nitric oxide comes from the endothelium. It is a vasodilator. Its job is to decrease blood pressure. And the way it decreases blood pressure is causing vasodilation, and that vasodilation causes a decrease in afterload. Something that's important to note is that nitric oxide has an inverse relationship to aldosterone. Not aldosterone, angiotensin 2. So, when angiotensin 2 is high, nitric oxide is low. So when we have an increase in nitric oxide, we have a decrease in angiotensin 2. Since nitric oxide vasodilates and angiotensin 2 vasoconstricts, you can see how that would help. This vasodilation would help to decrease afterload and decrease blood pressure for that failing heart. Okay, now there's a whole bunch of different categories of heart failure. I'm going to run through the definitions quickly, but the two that you're going to be responsible, the few that you'll be responsible for would be left-sided, right-sided, and acute decompensated. So, we have this category called systolic heart failure. Systolic refers to the pumping ability. So, it is the heart's inability to pump. Okay? It can't have forward flow. That is what most heart failures are. It's characterized by an ejection fraction less than 40%. Diastolic heart failure is a problem of filling. It's an inability of the left ventricle to relax enough that results in fluid backing up. And there's some speculation, I've read a few sources that would say that most people start with systolic with a pumping problem, but as the left ventricle becomes thick and hypertrophied, and it can't stretch, and there's been a lot of death there, then it leads to diastolic failure. And we have left-sided failure. Left-sided failure is the inability of the left ventricle to pump enough blood, causing fluid to back up into the lungs. Let me say that again and I'll explain it. Left-sided failure is an inability of the left ventricle to pump enough blood. So blood cannot be pumped out of the ventricle. So we have blood or fluid that backs up. So imagine this. So there's a roadblock. That's all that coronary artery disease. The left ventricle can't pump forward. It gets big and it stretches and it gets hypertrophied. But the blood still can't go forward. So it backs up into the left atrium. And when it backs up into the left atrium gets so big and so full, it backs up into the lungs. And when it backs up into the lungs, we get signs of pulmonary congestion. Remember the very first slide I showed you? The blood goes from the right atrium to the right ventricle to the lungs, from the lungs to the left atrium to the left ventricle. When we are talking about heart failure, it is poor forward flow, or the blood is in reverse. It's going back. It's not able to move forward. So, once again, left-sided failure, an inability of the left ventricle to pump enough blood forward, causing fluid to back up into the lungs. Right-sided failure. Right-sided failure is ineffective, inefficient pumping of the right ventricle. Okay, so that means ineffective pumping, a failure of the right ventricle to pump blood forward. So instead of entering into the lungs, this blood is going to back up into the right ventricle. It's big and swollen. There's no place to go. So it backs up into the right atrium. It's big and swollen. There's no place to go. So it backs up into the body. It causes congestion and fluid backup in the dependent areas, the abdomen, the legs, the feet, the sacrum. Acute decompensated heart failure. So we have chronic heart failure and we have acute decompensated heart failure. So acute decompensated heart failure is somebody who's been going along. We have the ability to compensate or not compensate. When we're compensating, our neurohormonal compensation is in place. We're changing our heart rate. We're changing stroke volume. We're kind of getting along. We're managing symptoms. Acute decompensated heart failure is an emergency situation. The patient is experiencing a very quick onset of symptoms. They may have been asymptomatic or mildly symptomatic, and then all of a sudden they decompensate. So they, like maybe they had an MI, or they had a change in medication, or any number of things that just all of a sudden the body's just like, I can't deal. We get like flash pulmonary edema. The left ventricle's not pumping forward. It's backing up into the lungs, and we have all this pulmonary congestion, pulmonary edema, altered tissue perfusion as well. All this backup into the right side of the body. So that is the heart's inability to pump. It is an emergency situation. As opposed to somebody who has chronic heart failure, who just is living with, and we are able to manage the symptoms. They're on diuretics. We have all kinds of medications, which we're going to talk about for that person, and they're getting along. Left-sided heart failure. Poor forward flow from the left ventricle. In other words, we have this coronary vessel that has all this atherosclerotic plaques in it. Afterload is very high, and the ventricle has already dilated. It's hypertrophied. It has hypoxia, so the force of the contraction is down. It has an increased demand for oxygen because it's working so hard. It cannot pump the blood out of the heart to the body. So where does it go? It backs up from the left ventricle into the left atrium, and from the left atrium, it backs up into the lungs. And when it backs up into the lungs, we have pulmonary congestion. So it can't have forward flow. That means that it can't pump blood forward. And if it can't pump blood forward, that's the job of the heart. The job of the heart is to pump enough blood to meet the oxygen and nutrient demands of the tissues. If we can't meet the oxygen demands of the tissues, we have altered tissue perfusion. And with altered tissue perfusion, we get ischemia, target organ ischemia. That means the target organs are the brain, the lungs, the liver, the kidneys. We get target organ ischemia, and that ischemia leads to death and eventually organ dysfunction. Clinical manifestations. All right, so there's two things that happen with left-sided failure. We have poor forward flow, which causes everything to back up into the lungs, blood to back up into the lungs. So we are going to have dyspnea, dyspnea on exertion, and exercise intolerance, maybe orthopnea. That means you can't lay back because we have too much fluid in the lungs. An unexplained cough, maybe blood-tinged mucus. That cough would be productive or non-productive in the beginning, leading to productive, working its way towards a productive cough. Sometimes it's blood-tinged. That cough is unrelieved by a change in position or even over-the-counter cough suppressants, crackles, wheezing, use of accessory muscles. All of these things are going to indicate a decreased oxygen saturation, are going to indicate that there's a lot of congestion down there in the lungs. And certainly, first off, that exercise intolerance, where a patient's going to report, I can't walk like I used to. I can't get through the grocery store. So you're going to have to elicit some of this information. And when we're talking about clinical manifestations, we really want to talk about the questions that you might ask to elicit some of this information. So you might say, ask the person, what makes your symptoms better or worse? Do the symptoms come and go with certain activities? Do they improve with rest? Are you having any pain now is important. Have you felt short of breath? Do you wake up short of breath in the nighttime? Do you wake up short of breath in the nighttime? Let's see, I'm trying to think of some others. Do you cough in the day? Do you use oxygen at home? Do you sleep in a bed? Do you sleep in a chair? How many pillows do you use? That indicates how much maybe orthopnea the person has. Have you recently spent a lot more time sleeping than you usually do? Things like that. Now, two things on the left side of the heart, backing up into the lungs, pulmonary congestion. Second thing, decreased tissue perfusion. Decreased cardiac output leading to decreased tissue perfusion. How am I going to know that? Well, I'm going to see it as a decreased O2 sat, decreased urinary output because the kidney's not being perfused enough, altered digestion as in like maybe paralytic ileus, slow peristalsis because the bowel is not getting enough oxygen, lightheadedness, dizziness, agitation, restlessness, confusion, muscle fatigue and weakness because they're not being perfused properly, cool, clammy skin, cyanosis or pallor, certainly tachycardia because the sympathetic nervous system is going to want to increase the heart rate, and maybe a decrease in blood pressure. Again, a lot of these are things that we can see. And we can try to ascertain things about confusion and the amount of urinary output through all of our assessment skills. Okay. Right-sided heart failure. So, right-sided heart failure is poor forward flow from the right ventricle. And that poor forward flow from the right ventricle is going to result in fluid backing up into the lungs. Poor forward flow from the right ventricle backs up fluid into the body. And the result is fluid volume overload, peripheral edema, venous congestion. Different way to say the same thing. Fluid volume overload, peripheral edema, and venous congestion. So the blood is supposed to come out of the right ventricle and it's supposed to go in the lungs. If the resistance is so high in the lungs that it can't push forward, backs up into the ventricle, and fills the ventricle, and then it backs up into the atrium, and then it fills up so much, it spills back into the body, and we see it manifested as an increase in blood pressure because of venous congestion and edema. Now I want to talk about cor pulmonale, or pulmonary heart disease is another way that they say it. There is an increase. This comes primarily from COPD. It is right-sided heart failure that comes from a respiratory problem. Let me say that again. It is right-sided heart failure that comes from a respiratory problem. So, normally we said that the pulmonary vascular resistance is a very low pressure system. But if the pressure in that pulmonary vascular bed becomes so high that it's very hard for the right ventricle to pump blood in there, we get right ventricular failure. But you're saying to yourself, how could the leading cause, COPD, cause pulmonary hypertension? Well, it's all about vasoconstriction. In all cases, whether it's from COPD or whatever the problem is, in all cases, hypoxia, not enough oxygen, hypercapnia, too much CO2, and acidosis cause vasoconstriction in the pulmonary vascular bed. So whenever you see that somebody has hypoxia, hypercapnia, or acidosis, it causes vasoconstriction in the pulmonary vascular bed. And that vasoconstriction causes high pressure. And that high pressure makes it difficult for the right ventricle to pump blood from the right ventricle into the pulmonary vascular bed. Now, somebody who has COPD, this vasoconstriction and eventual is actually a good thing, because let's say that I have let's go with I have pneumonia and I have a certain area of consolidation, and that area of consolidation is all filled with fluid, and I'm not getting oxygen to there. I can't do gas exchange in those alveoli because they're all congested with fluid. As a compensatory mechanism, what would happen is that area has hypoxia, it has a buildup of CO2, and so what would happen is those vessels would vasoconstrict. That would be great if they vasoconstrict, because then blood would be diverted or shunted to areas that have normal function, and then I have better gas exchange. But in advanced COPD, there's disease everywhere. So when there's disease everywhere, we have diffuse vasoconstriction. So we have all this increased pulmonary vascular resistance throughout the entire lung, which makes it really hard for the right ventricle to pump. It increases the workload of the right ventricle. The right ventricle begins to dilate, begins to try to compensate that way. Eventually it can't, and we get hypertrophy of the right ventricle, and we have a right ventricle that has right-sided heart failure, an inability to pump the blood forward to meet the, and it backs up, and when it backs up, it moves into the systemic circulation. Okay, so let's talk about signs and symptoms. And the signs and symptoms of right-sided heart failure are really related to fluid volume overload. And so when we talk about fluid volume overload, we talk about dependent edema. Certainly with fluid volume overload, we're going to have weight gain. Weight gain of 1 to 2 pounds per day or 4 to 5 pounds a week is something that we should teach our patient to report. We're going to talk about that in a minute. Right upper quadrant tenderness, because when fluid backs up, and right upper quadrant tenderness and this hepatomegaly go hand in hand, because the blood backs up into the right side of the heart and into the body, and we know that, and we'll study when we do hepatitis and cirrhosis, we know that there's portal circulation. That's the special circulation that supplies blood and filters the blood that's coming from our digestive tract. And it comes from the liver and spills into the inferior vena cava and returns. So when we have all this back pressure, we have all this pressure into causing liver congestion. So it backs up into the portal circulation. And backing up into the portal circulation, it increases pressure, it increases liver congestion. It's what helps to give the patients can have ascites. And so right upper upper quadrant tenderness, and the liver can be swollen as well as the spleen. JVD, because of all the fluid volume overload. And the presence of an S3 or S4 sound, indicating that there's, particularly S3, that there is fluid volume overload. And abdominal bloating and ascites, for the reason that we just talked about, all of this backing up of fluid causing bloating and eventually ascites from the liver involvement. Cachexia, a decrease in appetite, oops, spelled wrong there, I'm sorry, and nausea. And so a decrease in appetite and nausea could result in weight loss or malnutrition. Cachexia is different. When we talk about cachexia, we are really talking about not losing adipose tissue, but losing muscle mass. Muscle mass because the increased oxygen demands and changes. We'll talk about that in a little bit more. So the difference between cachexia and weight loss. One is really a catabolic effect, losing lean muscle mass, which is cachexia, versus weight loss, which is losing adipose tissue. And then this PND, paroxysmal nocturnal dyspnea. That's important. That is a sudden shortness of breath. They wake up in the night like gasping for breath, and they need to sit up because what happens is we have all this fluid volume overload, and it's third spacing. We have all this edema, what they call third spacing it's come out of our vessels, and it's in our interstitial spaces. And when we lay down at nighttime and we lay down, we are going to improve perfusion to our kidney, and we start to pull more water off. We're able to filter more fluid out. We lay down and we put our feet up, and fluid's moving out of the interstitial spaces back into the vascular space, and all of a sudden they feel overwhelmed with this fluid because the left side of the heart's having a hard time dealing with the extra fluid, and they have this PND where they wake up really short of breath. And again, it's really important that we use the proper assessment techniques: observation, auscultation, palpation, percussion, especially palpation and percussion when we're talking about fluid volume overload and we are looking to see if there's ascites. We talk about palpating the abdomen. If you do not feel comfortable with that type of assessment, get back and take a look at your Taylor book and make sure that you are proficient in all of the assessment techniques, including percussion, particularly of the abdomen for a patient who might have ascites. A word about the difference between orthopnea and PND. So orthopnea is they have lung congestion, and it's an inability to lay back. They feel like they're suffocating, so they sleep in a lounge chair, they sleep on pillows. PND, you lay down, you feel okay, and all of a sudden you get this wave of shortness of breath, and they have to sit up for a little while before the body can handle it and deal with it. So the other thing is we got to ask the right questions. So when we're talking about trying to gather information about right-sided failure, we're asking questions about what they ate, because salty foods are a bit of a concern. What did you eat? Did you eat something different than normal? Had you gone out for dinner? Do you weigh yourself every day? Have you gained or lost weight recently? Do you have any swelling? Do you have swelling every day, or in the day, or just in the evening? Do you feel bloated? How far up your legs? Do you have edema? But when we're explaining edema or you're charting edema, you should say whether it's +1, 2, 3, or 4 edema, whether it's pitting or non-pitting, and how far up the leg. Is it to the ankle? Is it to the mid-calf? Is it to the knee? Is it above the knee, thigh? How high is it? Where is that edema? Let's see. When you wear clothes, does it leave marks, like your socks leave a mark? Are your clothes tighter than they were, like looking for somebody who might have mild ascites? And certainly all of these things we would certainly be asking in both situations. We would be asking about medications. For the PND, you're going to ask, do you wake up short of breath at night? And if you do, how long is it before you can lay back down? Do you get relief? And one of the things for the left side of heart failure, when we're talking about dyspnea on exertion, that I should have said is you should ask the person, how many blocks can you walk without stopping? Can you climb stairs? Can you dress yourself without sitting down for a rest? Or any other question to try and elicit that kind of information for your patient. And I'm going to mention something here because the American Heart Failure Society uses this acronym called FACES, FACES, and I'm going to mention it. I don't use it because we have to know far more signs and symptoms, but they use FACES, fatigue for F, indicating right-sided failure, or left-sided failure, excuse me, because of the lung situation, limitation of activity, chest congestion or cough, and edema. So FACES. So fatigue, limitation of activity, chest congestion and edema, and edema. Let me look here. I'm looking at my notes to make sure. Okay, about the cachexia we talked about. So just in terms of differentiating between starving and malnutrition that might come from a decrease in appetite or nausea, that results in a decrease in adipose tissue, weight loss. When cachexia, we're talking about a loss of lean body mass that's greater than 10%. And what's important about this is that at one time it was thought that the patient was just losing weight and that cachexia, the loss of lean body mass, did not affect the myocardial muscle. But now we know that it does affect the myocardial muscle. So when someone has cachexia or is actually losing lean body mass, we're having a loss of muscle cells in the heart. And when we have a loss of muscle cells in the heart, and we already have a loss of muscle cells in the heart because of the hypoxia, now we have even a greater inefficient pumping system, which further leads to decreased cardiac output. It's a big vicious circle, a gigantic snowball. Let's talk about tissue perfusion and fluid status. Heart failure, decreased cardiac output, results in altered tissue perfusion. So when I say decreased cardiac output, you think the problem with decreased cardiac output is poor perfusion to the target organs. And we're looking for early signs and symptoms of poor perfusion to the target organs. And these that I have in red are for you to know and roll off the top of your tongue. Restlessness, confusion, anxiety. When the brain is not being perfused, restless, confusion, anxiety. When the skin is not being perfused, cool, clammy skin. When the kidney is not being perfused, decreased urinary output, less than 30 per hour. Of course, the O2 sat. Tachycardia may even be an early sign to try to increase circulating volume. But cool, pale and cyanotic skin, chest pain, maybe shortness of breath, GI disturbances, elevated bilirubin, these are all signs of decreased tissue perfusion. This slide is very important to you because we talk about tissue perfusion in almost every single lecture of this class. So these are things, this slide is something that you want to become ultimately very, very familiar with. You might even add to the altered tissue perfusion a decrease in the MAP, less than 60. And then there's fluid volume overload. Fluid volume overload, or fluid status, how much fluid we have on board, is assessed by weight and blood pressure. We can see it manifested as edema. We can see it manifested as pulmonary congestion. That would be dyspnea, orthopnea, exercise intolerance, dyspnea on exertion, cough or crackle, sputum, that cough that can't be relieved with change in position, the cough that can't be relieved with over-the-counter cough suppressant, JVD, ascites, hepatosplenomegalia. These are all really important things for us to consider when we're considering fluid status. And fluid volume overload is what we get when we have right-sided heart failure. Okay, let's talk about complications. Let's talk about the difference between cardiac compensation and cardiac decompensation. So when we talk about cardiac compensation, that's when we had heart failure, we have a systolic or a diastolic problem, we have a right-sided or a left-sided problem. It can be chronic or it can be acute. Either way, when we get those compensatory mechanisms, we are able to maintain cardiac output by adjusting heart rate, by adjusting stroke volume, and when those compensatory mechanisms fail, that's when we enter into that state called cardiac decompensation or acute decompensated heart failure. Acute decompensated heart failure is a complication of heart failure when all those compensatory mechanisms ultimately give out, and at some point, let me just say this, at some point those mechanisms that help for a while, when they are compensatory, eventually, ultimately, they become detrimental because they're increasing the workload of the failing myocardium. And sometimes that results in this decompensated heart failure. So that prolonged, I'm going to say, here's a definition. The prolonged, increased adrenergic activity leads to dysrhythmias, to increased energy use and cell death, and then we have cardiac decompensation. So I'm going to say that again. So we have all those cardiac mechanisms that work to increase stroke volume and increase heart rate, and they do a good job for a while, but ultimately they are detrimental because they increase the workload of the failing myocardium. Due to the prolonged adrenergic activity, that means the increased sympathetic nervous system, increased heart rate, and increased vasoconstriction, that leads to dysrhythmias and an increased use of energy and cell death, and then we have cardiac decompensation. As a complication, we have acute decompensated heart failure, abbreviated ADHF, which is an increase in all the signs and symptoms. It is often very sudden in onset. It requires immediate treatment. It is an increase in the signs and symptoms of decreased cardiac output and low perfusion, as well as you can add there, as well as the fluid volume overload, which is the pulmonary edema. Oh, I'm sorry that you're hearing that. I apologize. I'm starting and stopping. It's for this recording. It's summertime. I want it to be most current and most thorough for you, but I have a house full of kids and life going on here. But okay. So we have the decreased cardiac output, low perfusion, and you can also add their fluid volume overload. It requires immediate treatment. How are we going to see pulmonary edema manifested very quickly or early? We're going to see it initially. You might even see it as restlessness, agitation, or confusion, the cool, clammy skin, right? Because we're starting to see altered tissue perfusion, altered gas exchange. But the respiratory rate can increase up to maybe even 36 or so. A decrease in PaO2 and an increase in PaCO2. Later, you'll see it as tachypnea. Tachypnea and respiratory acidemia, acidosis, because why? As PaO2 drops, PaCO2 increases, and PaCO2 is an acid. And in order to respond to that acid, in order to respond to the PaCO2 elevation in the PaCO2, we have the tachypnea to try and blow off some of that, that CO2 load. And so let's talk about the treatments of, and what are we going to do for acute decompensation. Let me show you pulmonary edema. I like this demonstration here. Let's take a look at how the alveoli become congested. In number A, in letter A, you see an alveoli that's doing great. It's got air, it's filled up in there. You see a capillary that has blue blood representing unoxygenated and red blood representing oxygenated blood. And then we see a little space in there called a little interstitial space, pulmonary interstitial space. And that's where we do gas exchange. We move air in and carbon dioxide out. And when the pressure inside the vessel becomes so high, because fluid has backed up from the lung, we get this extra pressure in there, and the fluid moves out of the vessel into the interstitial space. And from the interstitial space, it moves and starts to move. In C, you can see some of the fluid is in the bottom of the alveoli. And in D, you see fluid has moved through the interstitial space into the alveoli. And that is pulmonary edema. And as that happens, we have a decrease in PaO2, a decrease in the amount of oxygen that we have, and we have an increase in the amount of PaCO2. So how are we going to treat acute decompensated heart failure? Immediate intervention following ABCs, airway and breathing. What are we going to do? Elevate the head of the bed, HOB that should be. Maintain the O2 sat 92% to high flow oxygen. BiPAP, intubation, ventilator. So we are going to want to use the least amount of oxygen therapy possible. So we might consider, maybe nasal cannula, maybe mask, up to high flow, non-rebreather, partial rebreather, BiPAP, intubation, ventilation for those that the work of breathing has become so great that it is very difficult for them. When are we going to, how are we going to evaluate that? Well, we remember, when we're talking about pulmonary edema and we're talking about PaO2 that's dropping, we're talking about the person having hypercapnia and the PaCO2 is rising. Remember what we said happens every time we have respiratory acidosis or acidosis of any sort. In this case, it's respiratory acidosis. Because of the hypercapnia, we have vasoconstriction of all those vessels in there. And that vasoconstriction from the increased pulmonary vascular resistance is making it more difficult for the right side of that heart to pump, further complicating the situation. So we're going to give oxygen, elevate the head of the bed, and get diuretics going. Get diuretics going so that we can pull some of that extra fluid off. Circulation. So we took airway and breathing. Now we're going circulation. We're going to look at ionotropes and ionodilators. What will an ionotrope do? An ionotrope is an IV ionotrope for this emergency situation would be dopamine, and we would want to give dopamine to increase the contractility and decrease afterload. We use it cautiously because it will increase dopamine because it will increase contractility, but in high doses it will also cause vasoconstriction, so we have to keep an eye on it. And then we have the ionodilators, which we use dobutamine or milrinone because they increase contractility and they vasodilate. The effects are measured with, in this emergency situation, with the pulmonary artery catheter, which we'll talk about in several weeks, how we handle pulmonary artery catheters. So again, airway and breathing, oxygen diuretics, head of the bed is elevated, get ionotropes going, an ionotropic dilator, vasodilators we can get going, especially one that we use is called nitroprusside because it rapidly decreases blood pressure. It's given IV. You have to do continuous BP monitoring. It's not just, every 2 hours or so. So there's the inotropes, vasodilators, control the rate and the rhythm. Right, so that's really important. A heart that's beating too fast, tachycardia will help to increase a heart rate, which increases cardiac output. But a heart that's going too fast does not allow for proper filling, and then that can lead to ischemia. So we need to actually slow the heart rate down, not super slow, but put the rate at a rate where we can allow for proper filling and improve cardiac output by improving stroke volume. And if a heart rate is too low, we got to get it up so that we can improve that. In addition, we know that with all this hypoxia to the myocardium, it leads to dysrhythmias. So we would want to give drugs that could correct any dysrhythmia that was there. And of course, you already learned that with Dr. Roy. So we're talking about ACE inhibitors and beta blockers. These are drugs that we will do in pharmacology. Those of you that have had pharmacology in the summertime, please go back and refer to those packets. And last, we're going to improve comfort. Improving comfort by giving morphine. Morphine will relax the person, decrease anxiety, but it will also cause some vasodilation. So it reduces preload and afterload, and it dilates pulmonary arteries and the blood vessels. So therefore, when we decrease preload and afterload, dilate the pulmonary arteries and blood vessels, we are going to decrease myocardial oxygen demand, thus improving the patient's comfort. Changing position, plan activities out so that we are not increasing oxygen demand. Certainly manage sleep and then manage environmental stimuli. What does that mean? That means lights down, TV down, not 100 visitors. A calm and reassuring environment is going to decrease O2 demand. Other complications that we see with heart failure: a pleural effusion. A pleural effusion comes because when we have lung congestion, we have an increased pressure in those pleural capillaries, all those little capillaries that were going around the alveoli. And then the fluid can move not only into the alveoli, it can move into the pleural space. And when it moves into the pleural space, that is a pleural effusion. So the fluid surrounds and then that pleural effusion, it surrounds the lung, and it puts pressure on the lung, which doesn't allow the lung to expand, and it does not allow for the ventricle to expand properly. And if that happens, the lung not expanding further impairs tissue perfusion and oxygenation. But when the pleural effusion becomes so large that it presses on the ventricle and the ventricle can't expand, then we get a condition called cardiac tamponade, which just means that the cardiac muscle has impaired cardiac output because it can't move. The third complication, atrial fibrillation and other dysrhythmias, comes because the heart gets enlarged. We talked about that remodeling, and it changes its shape. And when it changes its shape, the firing between the SA node and the AV node becomes off kilter, and it becomes chaotic, and often the person has the most common AFib. So we want to treat the AFib. because the AFib will put the person at risk for stroke from a thrombus or an emboli. Excuse me. Left ventricular thrombus. We said the blood is having difficulty moving out of the left ventricle. So we have a lot of stasis in there. Just like when we have AFib, you learned about AFib, and you have stasis of the blood in the atria, which can lead to a thrombus. We can have a left ventricular thrombus, which would form because the blood is not moving, which can put the patient at risk for thrombus or emboli. It also can impair cardiac output when you have a big old blood clot in there. Hepatomegaly. When we have right ventricular failure, the blood backs up in the system, blood backs up into portal circulation, and we have liver congestion. When we have liver congestion in there, we have cell death, and that cell death leads to fibrosis and cirrhosis. They call it cardiac cirrhosis. And then the liver's not doing its proper job. And then lastly, we have renal failure, which results from a decrease in perfusion to the kidney, which kills the renal tubules, and then that results, when 80% of them are impaired, that results in renal failure and fluid volume overload. All right, let's talk about diagnostic tests. I know you're getting tired. We're coming down the home stretch. Diagnostic tests. H&P. H&P is really important because we want to determine and treat the underlying cause. All those questions that we went over when we were talking about asking how many pillows, how far can you walk, do you wake up in the middle of the night, how's your swelling, how do you breathe, all those questions are part of gathering the history and physical. Let's talk about the laboratory studies. We're going to do a CBC and electrolytes. We want to know about whether the person has anemia, because we said that could be one of the causes. We want to do a BUN creatinine GFR because we want to determine renal function. We want to do thyroid function because we want to make sure if the person has hyper or hypoactive thyroidism. We're going to do that later in the semester. But if it's hyperactive, the heart is going really, really fast and working really, really hard. And if it's hypoactive, the heart's going really, really slow and cardiac output and tissue perfusion are impaired. We need to look at liver function to see if we have liver involvement. We want to look at a lipid panel. It tells us a lot about underlying coronary artery disease. We want to look at do a urinalysis, cardiac markers to look for cardiac damage. We want to make sure. And then we want to look at BNP and pro-BNP. And they tell us a lot about cardiac compensation. And when we talk about BNP, we talked about that being one of the counterregulatory mechanisms. And when the left ventricle has too much stretch, it releases BNP, and BNP, we went through, nature's diuretic, and it causes vasodilation, and it tries to adjust some of the other neurohormonal compensatory mechanisms. And so BNP is measured, less than 100 would be considered normal. 100 to 500 is considered probable heart failure. Greater than 500 is highly probable. And recently on the block is this NT-proBNP. And the proBNP is a more precise test. The reason it's more precise is because BNP has been the hallmark test for years and years and years. But the problem with BNP is it only lasts for a short while, whereas proBNP we see sooner and lasts longer, giving us a better indicator. BNP is measured less than 100, 100 to 150, and then greater than 500. proBNP is it depends on your age whether you're male or female, and age and male or female. So when you are looking at those statistics for a number, there's a big chart you'll see that comes from the lab, and you can find where your patient is. Okay, chest x-ray. We need a chest x-ray to determine the size of the heart and any congestion that the person might have. We're doing an echocardiogram. We can do a TEE, transesophageal echocardiogram, to get a 3D image. And we're doing it to evaluate the ejection fraction as well as any motion or valve structural abnormalities. So we can do a TEE, which is a 3D, or we can do a two-dimensional with Doppler flow to determine ejection fraction as well as any structural deficits that we might have. We can do, you need an O2 sat and you need ABGs to further evaluate for acidemia. You need a 15-lead EKG, tells you about myocardial ischemia, ventricular hypertrophy, any dysrhythmias that might be present. And oftentimes we're going to do a stress test to see, check out the coronary artery disease and any angina or ischemia that might exist. And lastly, the last and final most comprehensive diagnostic study would be the cardiac cath. All right, once we get a good thorough assessment of what's going on, it's time to start taking care of the person. So I said we treat the underlying cause and the contributing factors. If you got coronary artery disease, let's fix it. If you've got thyroid disease, let's get it fixed. Valve disease, let's get it fixed. And we manage it with medication or other types of treatment. So what are the goals? Let's improve cardiac function by decreasing preload, afterload, and patient symptoms. All right, what's that mean? So we want to increase cardiac function. That means we want to improve cardiac output. And the way we're going to improve cardiac output is by decreasing preload and decreasing afterload. We want to get rid of the signs and symptoms. We want to increase function of the person. We want them to be able to get dressed without sitting down. We want them to be able to walk up the stairs. We need to preserve target organs. So if you're having a hard time perfusing your kidney, we need to do something to get that kidney perfused, or you're going to have kidney failure too. We want to delay the progression. We want to improve lifestyle choices. Let's see, what else would I like to say about that? We want to decrease the work of breathing and decrease the amount of distress that the person's in. And of course, down there, decrease mortality and morbidity. That goes without saying, right? So what are we going to do? We got to improve oxygenation. We got to keep their O2 sat greater than 92%. We need to be monitoring either continuously every 2 hours, 4 hours, depends on how far along and where in the process your patient is, and your hospital's policy. We need to consider the need for a non-rebreather, BiPAP intubation, or ventilator support. We remember that we said that what can buy you a ventilator is that you have respiratory distress, and the work of breathing is so great. And the more respiratory distress you have, the more vasoconstriction you have, the more vasoconstriction in those pulmonary beds that you have, the worse your right-sided failure is. And we want to put you in high Fowler's position. And when you're in high Fowler's position, we want to have your feet either horizontal, laying flat, or dangling, because when we dangle your feet over the side of the bed, especially when you're in acute decompensated heart failure, we decrease venous return. We get the blood pools down in your feet, and it doesn't return to your heart. It makes it easier for your heart to deal with the amount of blood that it has. We want to provide emotional and physical rest, conserve energy, and decrease oxygen demands. We talked about giving morphine as being a way to decrease preload and afterload and decrease stimuli. And okay. Then we're going to move to circulatory support. And in circulatory support, so all these things that I'm going to mention here, you are going to have a whole class on critical care concepts and critical care equipment, and you will look at the intra-aortic balloon pump. But for right now, even though you don't really know what it is, you are going to say that the intra-aortic balloon pump will increase coronary blood flow and decrease the workload of the heart. So we'll use an intra-aortic balloon pump to increase coronary blood flow and decrease the workload of the heart. We will use a VAD, ventricular assistive device, to maintain the pumping action of the heart. It's a surgically implanted, battery-operated heart. It acts like a heart. It pumps the blood. So it's surgically implanted. It works by batteries. There's always a backup battery. It's very highly effective, especially in bridging, when we're trying to bridge to transplant. Okay, we could also have biventricular pacing. They also call that cardiac resynchronization therapy, CRT. And what happens is, remember we said that when the heart's has hypoxia, it can get dysrhythmias because the firing is chaotic. Well, when both ventricles aren't beating at the same time, it further decreases cardiac output, and it further increases the workload of the heart because it's not contracting properly. So there's a lot of evidence that suggests that everybody, it's a pacemaker, should have biventricular pacing. So both ventricles are being paced. So there's a lead in both ventricles, and it tries to synchronize the beats, which will improve cardiac output and decrease the workload of the heart. And in addition to that, we see right below it an ICD, an implantable cardioverter defibrillator. If you have a life-threatening dysrhythmia, you should have biventricular pacing with an ICD. So that is a defibrillator right in there. If you get a lethal arrhythmia, the pacemaker gives your heart a shock. Then we have percutaneous coronary intervention. They go in there and they the balloon, they blast open the coronary vessels to make perfusion a little easier, or coronary artery bypass, because we remember that 60% of the people with heart failure have coronary artery disease. We might even try to get to decrease intravascular volume, and decreased intravascular volume is done with the use of ultrafiltration or aquapheresis. So it's like a sort of like a dialysis machine that pulls fluid off. So for patients that were unresponsive to diuretics, we have this machine that filters their blood and pulls off all of the extra volume for them. And of course, the diuretic. Let's talk about the drugs, why we use them, and again, we will do them much more thoroughly. We go a little run through here, but we do them much more thoroughly in pharmacology. So if you had pharm in the summer, you better get that packet back out. All the drugs are used to decrease preload, afterload, increase cardiac output, and manage symptoms and treat the underlying cause. Let's look at the drug classifications. We're going to use diuretics. And the diuretics are going to reduce edema, reduce pulmonary pressure, and preload. So when we get the fluid that's in the interstitial space, we start pulling that into the renal tubules and excreting it. So we pull out of the interstitial space and then out of the vascular space. We get rid of that extra circulating volume. That decreases preload. And when I decrease preload, I decrease pulmonary pressure because there's less blood to back up into the lungs. And I can do that with a loop diuretic. And the loop diuretic that I can do that with is furosemide or Lasix, and bumetanide, which is Bumex. We have the thiazide diuretics, HCTZ. And we have the aldosterone antagonists, the potassium-sparing diuretics, that are going to block that neurohormonal effect of the renin-angiotensin-aldosterone system. So they're going to excrete sodium and water, but they're going to hold on to potassium. All right, well, we're going to want to take a look at the ionotropes that we talked about a little bit earlier. They improve contractility, they'll improve symptoms and increase exercise tolerance. When we're in acute decompensated heart failure, we give dobutamine, dopamine, or milrinone. They're given IV only with continuous blood pressure monitoring. We can also give digoxin. We can give it PO or IV to increase the contractility and therefore stroke volume and therefore cardiac output. Let's see. We are concerned with the ionotropes. Anything that is going to cause hypokalemia, like the use of the diuretics, the loop or the thiazides, can increase the risk for dig toxicity. Let's see. Natricor or Primacor, they decrease blood pressure and improve cardiac output. What do I want to say about that? They mimic BNP, so nature's diuretic. So they cause diuresis, they cause vasodilation, they cause a decrease in blood pressure and an increase in cardiac output. They're given in the ICU, IV only. We talked about morphine. Decreases preload, decreases afterload, increases comfort and decreases anxiety, and decreases oxygen demand. ACE inhibitors are the ARBs. They interfere with the renin-angiotensin-aldosterone system. They decrease blood pressure and they slow the progression of the disease. Some of the beta blockers decrease blood pressure and decrease afterload. They also will control some dysrhythmias. And then we have the final category here, nitrates and vasodilators. Because they vasodilate, they decrease preload, they decrease afterload. The drugs are nitroglycerin, given PO sublingually, PO IV sublingually, and transdermally. Nitroprusside is a very fast-acting vasodilator that we often use with acute decompensated heart failure. And the last one that I'll draw your attention to is Bidil, which is a combination drug used for African Americans. It's a combination of hydralazine, a potent vasodilator, and isosorbide, a nitrate, and that is approved for use in the African American population only. Quickly, I know you're getting tired. Nutrition is really important. Nutrition because sodium and water retain fluid. And we can't have any extra fluid. So, by restricting salt, we decrease the amount of sodium and water that are retained, and we decrease vascular volume or preload. So we do a sodium restriction, a 2-gram sodium diet. We follow the DASH diet. You did the DASH diet last year. If you don't remember the DASH diet, please go back and look it up. I'm telling you right now, if you do not look it up, there is a question on the exam about the DASH diet. You will get it wrong. We need to limit the number of processed meat, cheese, bread, cereal, and canned soup because they are very, very high in sodium. We need to read labels and teach our patients to read labels. It is very rare that we need to have a fluid restriction for these people. But because they are restricting fluid, we want to make sure, and we don't want them to become cachexic. We need to come up with ways to spice up food using lemon juice and things like that to improve and enhance taste. Teaching, teaching, teaching. Dietary restrictions and reading labels, how to do that. Dietary is often consulted and gets involved. Weight management, we're looking for weight reduction to control blood pressure. We are looking for them to weigh themselves every single day. We are looking for over 3 pounds in 2 days, 3 to 5 pounds in a week. We teach them to weigh themselves wearing the same things at the same times every day. We have to teach them when to call the healthcare provider. So that means teaching them signs and symptoms that their heart failure might be getting worse. Dyspnea on exertion, a change in weight, anxious, can't sleep, must use extra pillow, socks are tight, pants don't fit anymore, because abdominal girth is changing. So all these types, all those signs and symptoms that we talked about that would indicate that they're getting worse, you would have to teach those and when to call the healthcare provider. And certainly all the medications and how you use them and proper compliance, side effects that the person might have, and teaching them to take their medicine, teaching them about their illness and that there is no cure and that they must take their medications. Each of the hospitals usually have some heart failure compliance teaching, packets that go out to people to make sure everybody knows what they're doing. Possible nursing diagnoses: decreased cardiac output. And because of decreased cardiac output, there is altered tissue perfusion, perhaps impaired gas exchange. Right-sided failure gives fluid volume excess. Because of those things, we have an activity intolerance, anxiety, and a knowledge deficit. We will work with those in class to develop them more thoroughly. How do you know your treatment was effective? You know your treatment was effective when the weight is down, the blood pressure is down, the O2 sat is up, urinary output is greater than 30, skin is warm and dry, and maybe or maybe not confusion. They tolerate activities. They are knowledgeable about the disease process. Their lungs are clear. That's how I know my treatment has been effective. That left-hand column is critical because those things can happen on the left-hand column before the lungs are clear, before the activity is tolerated, before they are knowledgeable, but their blood pressure can be in check, their weight can come down, their urine output indicating that their kidney is being perfused, and their skin warm and dry. So the left-hand side is early signs that they are getting better. Thank you, thank you, thank you. Thank you for your attention. 2 hours and 7 minutes is a long time. I apologize for any of the background noise that you hear. Like I said, I'm trying to do this at home, and I thank you for listening.